Thank you, Dr. Rita, and thank you to the scientific committee for having this interesting IC. And to begin with, Dr. Sunil has made my job easier, and because he's discussed part of what I would be speaking. And when do we test for ocular perfusion and sleep apnea? Whenever we find that the glaucoma progression is and this would we all know that glaucoma damage may be caused by vascular factors like low perfusion pressure and ocular blood flow, and these conditions could affect not only the occurrence but the progression of the disease. And there are several studies in which have found that alterations in systemic and ocular hemodynamics plays a significant role in the progression and development of the disease. Before we go on to further, we should always revisit our diagnosis, check for patient compliance, and ensure that we have not missed the angle closure component if the patient has been on follow-up with us for a long time. I would begin with my discussion with this 80-year-old lady who was on a 10-year-old follow-up. She was her IOPs were never more than 15. She had a very good compliance.
Meenakshi, your slides are not moving. Sorry. Yeah.
So without having to repeat this, I will go on to discussing this patient who had an asymmetric visual field loss, more in the right eye, and her IOPs were always normal. We did an ocular blood flow for this patient, and we found that the resistive index was high in the right eye. And we started the patient on a carbonic anhydrase inhibitors, and lo and behold, we could see actually not only that the progression had halted, but the vision had improved. The fields had improved. From 2019, she had to actually stop ASOPT as she was intolerant to it because of dermatitis. And we can again now see that the patient has progressed. Again, now we have started the patient on dorzolamide. This patient, we all know that there are lots of patients who progress despite IOP control, and it has been substantiated by many population-based studies. And the ocular blood flow is the distribution of oxygenated blood supply throughout the vasculature to the eye. The average blood flow is lesser in glaucoma, and there is a decreased blood flow is correlated with visual field defects. And as we will, the ocular blood flow is reduced in the retrobulbar, the retinal, the optic nerve head, and in the choroidal circulations. And it may be actually the first deficit which occurs, which is the first manifestation of glaucoma. There are many vascular risk factors, apart from the systemic ones, which Dr. Sunil has already discussed. There is the aging of the vasculature. There is the ocular perfusion pressure, which he had alluded to. Also, there is a reduction of ocular blood flow, and fluctuating and unstable blood flow. Also dysregulation of ocular blood flow, which may occur in patients with vasospasm, either because of migraine or the recently introduced Flamer syndrome, and also due to a certain hypovolemia. When we look at think of the glaucoma as a type of ischemic optic neuropathy, we also find that the abnormal optic nerve perfusion pressure has been known to play a major role in the pathogenesis of normal tension glaucoma, and 20 to 60% of our Indian population in varying areas is an NTG. So we should look at this aspect of patients' glaucoma. And we know that as a person ages, there is the increased resistivity of the index of the retrobulbar vessels, and this really leads to a decrease of thalamic, arterial, and systolic velocity, and decreased ocular blood flow. Also, with aging, there is progressive decrease in the thickness of the choroid, and this also decreases the circulation. The 47% of the glaucoma patients have systemic hypertension. This already Dr. Sunil has covered very well. I will not go ahead with this. But we also know that patients who are diabetics have a vascular damage and vascular disturbances of the optic nerve, and their autoregulation is affected. So in these patients also, we should look at their ocular blood flow. Then again, patients who have migraine, and they have in the elevated levels of endothelial-1, which is a powerful vasoconstrictor, which may be causing vasospasms and disturbed vascular autoregulation. And in these patients also, we should do a ocular blood flow. And the low ocular perfusion pressure also has been identified as an independent risk factor for glaucoma progression. We calculate the ocular OPP by the mean OPP by adding the DBP to 1/3 of the difference between the systolic and the diastolic blood pressure. Normal OPP is between 41 to 61, and a low mean OPP has been associated with glaucoma progression when the IOP is normal. And there are many population-based studies which have found that there is a 2 to 6-fold increase in the incidence of open-angle glaucoma, with the diastolic OPP being less than 55. And this is substantiated by many other population-based studies. Also, there is the ocular perfusion pressure is reduced in POAG. There is a lower diastolic perfusion pressure, which is a new predictor for disease progression. There is 50% rise in risk for progression. Vascular abnormalities are an important risk factor both for development and progression of glaucoma. Athletes, although they have low OPP, they have a good autoregulation, hence they do not have any problems. Patients who have Flamer syndrome, they are the ones who have a long increase in the long-term fluctuation of visual fields, and they are generally people with low body mass index with a low BP. And it has been found that they do have vasospastic syndrome, cold extremities, which Dr. Sunil had also alluded to. And these people can have a multitude of ocular problems apart from NTG, AION, and vein occlusions, etc. So we should think of doing OBP in such patients. And now coming to the effect of anti-glaucoma medications on ocular blood flow, timolol does not affect ocular blood flow. Apraclonidine has a deleterious effect on the erythrobulbar circulation. The other beta blockers like the levobulinol, bitoxolol, and also the brimonidine, latanoprost, acetazolamide, and topical CAIs increase the ocular blood flow. Also, bitoxolol, cartilol, latanoprost, and bimatoprost decrease the resistance of blood vessels. Acetazolamide and uniprostron have found to be have anti-endothelin 1 effect, and bimatoprost increases the OPP, as well as it decreases the RI. And so both prostaglandin analogs can be used to improve ocular blood flow. The major focus of ocular blood flow has been seen that CIAs increase the blood flow velocities in the central retinal artery as well as the short posterior ciliary arteries, but not in the ophthalmic arteries. Carbonic anhydrase inhibitors do cause vasoprotection. They improve the autoregulation and also increase the choroidal blood flow. And there are many studies which have been done on, more studies have been done on dorzolamide, and a meta-analysis of the same has put forward that there is an increased blood flow velocities and decreased vascular resistance in the retinal circulation by using the CAIs. They also improve the ocular blood flow and delay the visual field progression. They also shorten the AVP time. In comparison between dorzolamide versus brinzolamide, dorzolamide has a 6.5 times more affinity for the carbonic anhydrase 4. But brinzolamide improves the peripapillary retina blood flow and is probably more gentler to the cornea. And there is one study which found it to be more efficacious. Now, brimonidine also enhances the autoregulation. So one can use either of these. There are some systemic drugs also which increase ocular blood flow, which is the trandropyl, dipyrimidol, ginkgo biloba, and magnesium. Their effect can be utilized. Now, how do we measure the blood flow is the one which is most prevalent and most often used just now is using the color Doppler imaging. And here we can identify the central retinal artery, the short posterior, lateral, and temporal arteries, and the ophthalmic arteries, and calculate the vascular, the end-diastolic volume, velocity, the peak systolic velocity. But the factor which is most important is the resistive index, which is actually a ratio and has been found to be correlating with the ocular blood flow. It is one of the most reliable parameters on OBF, and greater than 0.76 is considered as a high RI. Progression of visual fields correlates with high RI in POAG as well as in NTG, but not in angle closure patients. This was one of our studies which we had done in where we took glaucoma patients with open angles with the 4 or more visual fields, and they found progression on visual fields. And we found that patients who had progression were put on carbonic anhydrase inhibitors, and we could actually correlate between low OPP. We could actually find that these patients, the visual fields improved once we had put them on CAIs. I will not go into these examples. Coming on to nocturnal hypotension and sleep apnea, they both may contribute to fluctuating ocular perfusion. Obstructive sleep apnea disorder is characterized by repetitive episodes of shallow breathing, and this increases 10 times more likely to develop glaucoma. The literature on this is very, it tells us that there is a prevalence of NTG in obstructive sleep apnea syndrome. In a patient with NTG, there is controlled IOP with progression. Whenever there is high BMI or there is a history of suggestive of sleep disorder, we should investigate them, and we should take a good, accurate history of this of sleep, and we should refer such patients with sleep disturbance for polysomnography. But what was actually found when they tried to put a contact lens which could measure the IOP while the sleep study was on, was that the IOP actually decreases during the apneic episodes. So the high IOP was actually found more related to the obesity, the supine position during sleep, and raised ICT. So what they found was the visual field defects were actually due to retinal ischemia in the apneic phase and not due to the IOP changes. So there were associations between glaucoma and abnormal. I'll just take half a minute. Abnormal sleep duration and sleep latency and daytime dysfunction. High IOP due to related and the high diurnal variation was found in patients who were put on CPAP machine to cure the sleep apnea, and in them there is a more than 10 times higher risk of glaucoma. So patients of sleep apnea who are put onto CPAP, they're the ones who should be followed up for glaucoma. There have been OCT changes found in patients who have sleep apnea. There is thinning of RNFL, and especially there are different studies. Some have found the supratemporal thinning to be more important. There were others in which they found that the inferior quadrant and thinning was more often seen, and the temporal quadrant thinning was least often involved. And there are patients who have floppy eyelid syndrome, and this could be an indicator of glaucoma in patients of sleep apnea. This was our study which we had done, and in that we found a very high incidence of glaucoma in our sleep apneic patients, but it could also be skewed because we had actually taken, it's a very small group. So in nutshell, I'd like to say that systemic hypertension, all these things together, if they are present, we should do an ocular blood flow. The take-home message is that POAG is associated with an alteration in factors related to OBF and a breakdown of autoregulation. When progression occurs in spite of controlled IOP, vascular factors should be emphasized upon, and treatment should be emphasized. Glaucoma medication should also be evaluated on the ability to increase OPP and blood flow. In future, we may have a normative database of blood flow parameters, and which may help us to look at these much in a better way. And also maybe medications like statins would be used to improve the ocular blood flow as well. Thank you for patient hearing.